So it's being rescheduled. My apologies for that on behalf of the organization and on behalf of Chris. So we have the bone and the nerves left, but I can tell you from experience, these two talks will give you enough information to, to keep your brain working for many days. We have two fantastic speakers, William Jeffcoat and Nina Petrova, who is taking over the job from Mike Edmonds, who could not be here, unfortunately, due to some illness. William is somebody who hardly needs any introduction. I think all of us know William. He's been involved in the diabetic foot since the early 80s. And together with Fran, he established the ulcer trial unit in Nottingham, where many, many trials have been performed. And he's, with Fran, somebody who has actually done most of the trials in that unit, intervention trials on diabetic foot ulceration. Moreover, William has a long-standing interest not only in wound healing, infection, osteomyelitis, but also particularly in Charcot. He has been organizing himself meetings about this. He's been writing some beautiful reviews about this. And I think we are looking forward to hear a very interesting talk by William on this topic. William.
Thank you very much indeed for that introduction. It's a pleasure to be here. David, I'm sure it's David, has had this sequence of puns and extended and rather tortured metaphors in the titles which he's given us. So we all have to try and dance to David's tune. So I'm going to do the same and talk about Charcot expressionism and framing an unclear picture through genetic testing and diagnostics. I always do what I'm told. So that's what we're supposed to be talking about, what I'm supposed to be talking about. So I thought I'd start off just by illustrating some expressionism. And for the Russian people in the audience, this is Kandinsky. And just to try and test David's theory that framing things makes them clear, I thought I'd just try and test it for you. And I don't think it's any more clear at all. So here's my expressionism. This is the expressionism of the pathogenesis of the Charcot foot, which various versions of have appeared in various places over the last 10 years. But let's try and simplify it and frame the expression of Charcotism. And if I try and see if I can that's good. And the whole process is based on a cycle whereby there is an episode of inflammation, pro-inflammatory cytokines trigger the inflammation, which then leads through a signaling pathway. The rank L, NF, kappa B is certainly one that's been identified. That leads to osteoclast maturation and then to bone breakdown. When the bones break down, the bones become thin, and then there is fracture of the thinned bones, and then the situation continues. And it's made worse, of course, by neuropathy, because the person can't feel, so they will be unaware of the extent of the trauma in their foot. They'll continue to walk on it, and that causes more inappropriate loading and fracture. Charcot himself was studying cases of syphilis, of course, of tabes dorsalis, and the neuropathy of syphilis is completely different from the neuropathy of the peripheral neuropathy of diabetes. It's tabes dorsalis, where you've got loss of deep pain sensation and loss of proprioception, whereas in peripheral neuropathy you've got a different modality of pain loss as well as soft touch. And in diabetes, the situation is very similar to that in other peripheral neuropathies, such as leprosy, which of course is long established. The Diabetes Association was not first described until 1936. Charcot himself described the Charcot foot in 1883, and Lee Sanders' paper from a couple of years ago pointed out that actually Charcot wasn't the first person to describe this, but it was described by somebody called Page in 1881, and Charcot knew full well about it as well. But that's another story. And apart from diabetes and leprosy, then other peripheral neuropathies can lead to the Charcot foot, and the one that we come across most is alcohol-associated neuropathy. But as I'm in America, I must mention father and son, J.K. John Kearsley Mitchell and Silas Weir Mitchell, who respectively described Charcot-type changes, father in the 1820s from someone who had tuberculosis of the spine causing root compression, and then son in the American Civil War describing it from gunshot injuries. But I won't dwell on that, the different causes, but the point I'm trying to make is that neuropathy is the linking theme, even though these are completely different diseases. And the neuropathy is not just sensory neuropathy, as shown in the top of the picture here, but motor neuropathy, of course, which causes change in the structure of the foot, change in the way in which gait is transmitted through the bones and joints, and exacerbates, perhaps, the forces expressed on the foot. Now, you all know that. But it's not just sensory and motor neuropathy. There are other modalities of neuropathy which can also be affected in any of these different conditions, but it's diabetes that we're most concerned with. And there's what I've called peptidergic neuropathy, because nerve terminals normally release peptides, mainly, not exclusively, which are effectively hormones, into the tissues. And when the nerve fibers die, then those agents are lost. And we're increasingly aware of the significance of this in diseases such as the Charcot foot, and particularly the loss of peptides like calcitonin gene-related peptide and substance P. And I mention those in particular because calcitonin gene-related peptide actually suppresses the production of RANKL and therefore NF-kappa B. CGRP suppresses the inflammatory process, and so it's another factor which makes this inflammation expressed in this disease. Also, a thing which we don't know, we don't really think about why joints dislocate. You know you get apparently spontaneous dislocation of the metatarsophalangeal joints or the interphalangeal joints in people in neuropathy. We don't know why. We say it's imbalance of long flexors and extensors, perhaps. But there is very good animal data that the joint capsule is very richly innervated by nerves containing, amongst other peptides, CGRP. And so it's not just perhaps that the capsule is, in the case of Charcot, detaching from the bone, but the capsule itself could be abnormal, and in other words, more distensible and more likely to dislocate. This has not been investigated in any detail, as far as I know. Other modalities of neuropathy, which we get, no matter again what the cause is, relate to the blood supply. And there are different aspects of vasomotor neuropathy. One of the earliest series of papers looking at Charcot with 3 separate groups all described a very interesting abnormality in people who had had Charcot in the past. Let me sidetrack and say that when you look at people with sensory neuropathy, with distal neuropathy, as in diabetes, and you warm the skin, typically you do not get vasodilatation when you warm the skin in a neuropath, which you would expect in someone who hasn't got neuropathy. But the distinguishing feature of people who've had Charcot is that that vasodilatation in response to warming of the skin is preserved. And maybe this is one reason why, when neuropathy is so common, Charcot is uncommon, because it's only a small subset in whom they've retained the capacity to vasodilate in response to whatever stimulus. But it's not just that which is abnormal. There are abnormalities about vasomotor constriction and vasodilatation, shunting of blood, and changes in the structure of the medium to small arteries, and in particular the presence of vascular calcification. And I'm grateful to this illustration here from Yvonne Alexander in Manchester, showing the calcification within the media, tunica media of the arterial wall, which is actually not calcification, but is new bone formation. And when we look at Munkeberg's sclerosis on X-rays and we see those tramline calcification on the foot, this is what's going on, that you're getting new bone laid down in the arterial wall, and it is seen in the foot because it is a complication largely of neuropathy. And of course, that's where the neuropathy is worst. And on this slide, I've also introduced the concept of another signaling pathway. Some years ago, Nina Petrova, who's to follow, described evidence to suggest that perhaps Rankel NF-kappa B wasn't the only signaling pathway, and there might be another one. There is another candidate signaling pathway, and I'm sure there will be more. This one is called Wnt Beta-Catenin, whereby it's independent of this pathway, but it does show similarities in the sense that it is also seems to be associated with arterial disease and with arterial calcification as well. So you can see there are lots of manifestations of neuropathy, whether it's diabetes or not diabetes, which all contribute to this expression of the Charcot process. And the last one I want to highlight is this question of denervation of bone. We're only becoming dimly aware now of the significance of bone denervation. Bone is richly innervated, which is why it hurts when you break a bone, but the evidence is apparent that the bone, and in particular adrenergic nerve fibers in bone, are greatly reduced in people who've got distal neuropathy. But we know little of the significance of that, just as we know little of the role of bone in modulating carbohydrate metabolism. And this is again a very exciting growth area where osteocalcin in particular seems to be important in modulating insulin resistance. So we have a whole new horizon of metabolism to discover, but that's slightly irrelevant. But the relevance of the denervation of bone in this circumstance is that it is associated with bone thinning. So it's quite reasonable when talking about Charcot to give it the name neuropathic osteoarthropathy, which is that sort of mouthful name that everybody uses. And here I've got a picture of a patient I was looking after a few years ago, showing the foot when it first presented, inflamed and swollen, and then a few years later the same foot now no longer with disease activity. But the term neuropathic osteoarthropathy doesn't highlight the important detail, which is the inflammation. And I think we should start to be talking about neuroinflammatory osteoarthropathy if we want to use these long gobbledygook terms. But while I've got these pictures, and talking about words, I just want to say one more thing. We talk about acute Charcot. Well, it's a stupid term because the thing goes on for months. We don't even talk about subacute Charcot. So how can we describe something as acute when the disease process lasts for months and months and months? And Ernst Chantelau in Germany has recently suggested a new classification for Charcot in which it's divided, amongst other things, into active Charcot and inactive. And I think active is so much more appropriate than acute, and I suggest that perhaps we all think of adopting it in the future. So back to my expression, my pathway and the expression of it. Diabetes itself is the thing which interests us. Diabetes is associated with grumbling, increased inflammation anyway, unrelated to any other episode which might trigger an acute Charcot foot. And this itself is related to increased lipid production, to oxidized lipids in particular, to reactive oxygen species and advanced glycation end products. All of those acting together to perhaps enhance the inflammatory pathway mediated through Rankel and NF-kappa B. But I was asked about genetic testing and also about diagnostics. Well, what I'm trying to do is to show that we have a very complex situation with a lot of different potential pathogenic pathways stimuli, all mediating, but all in the end coming down to a common pathway, which is what we recognize as the Charcot foot. And so to go looking for a genetic marker, it's a nice idea, it's clean, but I'm not convinced. There are 2 papers that I know of, maybe there are more if I've missed, but there's certainly one from Italy and one from Poland, describing polymorphisms for osteoporotegerin, which is a peptide which is released with RANKL. So when RANKL's up, OPG goes up as well, and showing some changes in people who've had Charcot and people who haven't had Charcot. The Charcot people seem to have a different expression of OPG polymorphisms. But the odds ratio is only just over 2. And sadly also, the 2 groups described slightly different polymorphisms. So the odds ratio is not high enough. There's some discrepancy in the meager literature that there is, and I'm not convinced. It might be important in a small number as being a critical factor, but I don't think it's a dominant causative process. The other one is, what about measuring things? Well, we've tried it. Nina Petrova's also tried it at King's, and she's published a paper very recently in Diabetic Medicine describing some of the changes which you might observe. It would be lovely if we could find a marker to emphasize the involvement of this pathway, this pro-inflammatory NF-kappa B pathway. And it would be lovely if it showed high levels of the things we wanted to show, and they came down as the disease got better. The answer is they show some things going up, and we might be measuring signaling pathways, peptides, like RANKL itself, or we might be measuring OPG, or we could be measuring bone turnover markers or whatever, in other words, a little bit further downstream. But they don't, some of them are a little bit high, but our experience anyway, and Nina will correct me, I'm sure, is that they're not consistently high, even though some of the ones that are high do fall as the disease settles and goes into the active phase, into the inactive phase. So it's possibly a clue. I don't think it gives us. It'd be nice to have it there to confirm that these are the pathways that are involved, but the support is not that strong at the moment. I'm going to finish by just looking at this particular corner of this pathway once again, and to emphasize that, of course, this isn't the only way in which bones get broken down. Malignancy will cause a breakdown in bone, and so does infection, and this is obviously relevant. And there are lots of mechanisms whereby infection causes bone breakdown. I've listed some of them from the recent literature here, but RANKL expression is certainly common to some of them. So if we're looking at a situation whereby you have chronic inflammation, increased RANKL expression, and then bone breakdown, and we want to see it as part of the Charcot, we've got to think of it also as part of other diseases which we also encounter. So a very similar sort of pathway could occur in people who haven't got signs of Charcot. If you've got a chronic ulcer, for instance, there will be inflammation underlying it, even though the foot is not hot and red, and there will be associated changes of inflammation. And so inflammation from chronic ulceration or adjacent soft tissue infection could cause bone lysis without necessarily there being infection of bone. So you can have any adjacent inflammation could cause breakdown in bone, and it doesn't necessarily mean that that person has got infected bone. So this is what I've tried to skate over, a very complicated, complex, interacting group of pathogenic mechanisms. This is my expression. Now, is it better if we frame it? And the answer is no. So I'm going to finish up just with 3 slides very quickly. This is really the summary slide. The others are my attempt to get back at David. So the active Charcot foot is the expression of a process occurring in people with overlapping neuropathies. Different people, different types, syphilis, diabetes. mediated by abnormal monocytic responses, in other words, monocytes, macrophages, which actually convert to osteoclasts, I mean. But it's a syndrome, it's not a discrete disease. We recognize it because it presents in a certain way, but it's actually just the expression of a much wider, complex, overlapping metabolic process. So we've obviously got to learn more about it in order to unravel it, but I want you to think laterally, and actually the same processes which we're pondering in Charcot could be very important also in the chronic unhealing ulcers that we have to look after, as well as in cases of osteomyelitis. So, framing an unclear picture through genetic testing and diagnostics, I've put genetic testing and diagnostics on one side, and I'd like to say, well, we need to keep looking for the trees, but we learn a lot more if we look for the wood at the same time. I couldn't decide which of these two slides to put in, so in the end I put in both, and I'm sorry if I've gone on too long. Putting an expressionist work into a frame doesn't take us much further forward while we are still looking through a glass darkly. And I think we are looking through a glass darkly, Chairman. Thank you very much.